Hello,
DP sir, please unmute.
please, sir, over to you, sir. DP Singh, sir.
I'm extremely thankful to our organizer, my friend Dr. A.K. Birimani, scientific chairman, doing a very good job, a great program. And my task has been to discuss about the challenges posed by diabetes and TB. Friends, in next 20 minutes, I will try to give you a brief review of how the diabetes and TB is creating the syndemic, twin epidemic, how TB potentiate that diabetes and diabetes potentiate the TB, how we can screen and diagnose, and what are the challenges, what are the situations these twin epidemics are posing to us. We know historically TB is closely associated with the TB in the shadow of DM, and Indian physicians Sushruth described thrice frequently complicated diabetes. And in 83 long back, autopsy of diabetics showed presence of TB granuloma in as high as 50% of diabetics. You know, the insulin discovered in 1922. Before this era, diagnosis of DM was a death sentence, and leading cause of death was tuberculosis. During these days, a patient with diabetes who do not get diabetes is likely to die of TB. This Howard Roop, that physician from Boston, he did the autopsy study. They concluded that type 1 was associated with tenfold increase in risk of TB. In 1944-45, you know, that there is discovery of streptomycin and the incidence of TB started going down. But again, in 1990, diabetes started coming up. And then in 2012, there was collaboration between this Global TB Union and WHO, and there was Bali Declaration. From there, a lot of work has been started to tackle this in epidemics, that is TBDM. And this is the epidemic, you know, that more than 463 million people living with diabetes just now. It may go to 700 million maybe in 2040. India being the capital of diabetes. Similarly, despite all the anti-tuberculosis drugs, still we are having more than 10 million people. There's 1.2 million dead. Again, this corona, this end 2025, that and how long and how far it will take to end the TB program, we don't know. But this combination has created a lot of problems, and there's a big concern about these twin epidemics. In low to middle income group countries like India, we have got a lot of problems. TB increases the risk of diabetes twofold, but diabetes increases the risk of TB threefold more. So if you see this situation, if there is tuberculosis, we can control it by drugs. But if TB is associated with diabetes, the problem becomes uncontrollable and difficulty are there how to control it. Because the hyperglycemia in diabetes favors the growth, viability, and propagation of tubercle bacilli. Increased availability of glycerol causes the growth of tubercle bacilli. High level of insulin also causes the TH1 immunity to be lowered. There is abnormal chemotaxis. There is monocytes or macrophages has got loss of capacity to phagocytose and kill the tubercle bacilli. Poor blast formations are there of lymphocytes so that the mediators are released less. And all these will promote the development of tuberculosis. And you know that there are many risk factors, but apart from HIV, diabetes becomes the very dominant risk factors and increasing the prognosis and the pathogenesis of diabetes, this tuberculosis. Whenever the infection of tubercle bacillus that enters in our body, they may go into the latent state. And out of lifetime, 10% of the people can get active tuberculosis, but this tuberculosis can be controlled. There will be low chances of recurrence. There will be no drug interaction. There may be no chance, less chances of MDR tuberculosis. But once there is entry of this diabetes mellitus, immunocompromised occurs, this form of TB-DM combination will become uncontrollable. Chances of recurrence will be high. Treatment may be longer. Drug interaction will be more. So this is the situation brought by this combination. And if you see the pathogenesis, how this diabetes enhances the tuberculosis, this MTB infections, the macrophage without diabetes, then they will engulf this tubercle bacilli. Cytokines will be released, this interferon, interleukin 2, 12, vitamin D, TNF alpha. They all will release of a reactive oxygen species, and they will kill the tubercle bacilli. But in diabetes, all the mediators will be depressed, phagocytosis will be less, the chances of survival of tubercle bacilli will be more, and that will create all sorts of problems. And these are the simply the diabetes, there is reduced immunity, reduced mediator, reduced phagocytosis, and tuberculosis because of stress, infection, different mediators that will cause insulin resistance, may increase the blood sugar may be high. Even there are chances of, although rare, T pancreatitis can be there, pancreatic endocrine hypofunctions will be there, and diabetes may be increased. This diabetes may be increased by tuberculosis itself, and this process cycle may move on. What is the consequences if this TB-DM are combined? It is seen that it is more common in older age. This combination is may be there. In if you see the gender reports are there that male may be more commonly involved than the female. Symptoms of diabetes and TB, they are usually same, weight loss and fatigue. But some literature states that the body weight of TB-DM patients may be more than the TB alone. Extrapulmonary manifestations are less, rather the more and more cases of pulmonary TB are seen. Whether the diabetes is a risk factor of TB, there are lots of robust data that shows that diabetes increases the TB risk by 2 to 7 or 8 times more. And even in the among TB patients, diabetes prevalence is variable from 2% to as high as 35% after screening. And even this type 1 diabetes is also very much common, 3 to 5 times. So this incidence of TB diabetes is very great. Whether TB is a risk factor for diabetes also, although there is a bidirectional relationship between diabetes and TB, but dedicated studies to assess whether TB increases the risk of diabetes are few. There is TB can cause impaired glucose tolerance and you onset diabetes, but the good news is that this IGT will normalize after the TB has been successfully treated and remains a risk factor for developing type 2 diabetes in future. This TB may worsen the glycemic controls in the previously diagnosed tuberculosis, diabetes mellitus. So what is the impact of diabetes on pulmonary tuberculosis? It will cause the more extensive agglutination, more physician, more toxemia, hemoptysis, fluid fusion are seen frequently. Hilar and basal regions are more involved, and diabetes may be a risk factor for hepatic toxicity. And once you treat the patient, the outcome may be possible drug-resistant tuberculosis. So radiological appearance are atypical. There may be involvement of lower lobe tuberculosis with cavitation. There may be with cavitations may be seen. How to screen? All patients of TB must be screened for DM as we do for HIV, fasting blood glucose 126 milligram, or this fasting blood glucose in between the 110 to 125 with the IGT. Patients random blood sugar more than 200, in between 100 to 200, suggestive of retesting, and should be screened in the next patient visit. Confirmatory assays such as OGTT or estimation of HbA1c can be used for cases primarily blood glucose. A study from South India had compared the performance of HbA1c and fasting this blood glucose. And HbA1c was a better diagnostic tool for identification of newly diagnosed DM. So whenever we screen a patient of tuberculosis for diagnosis of diabetes, it is a better tool, better guide that HbA1c should be also taken as a diagnosis. HbA1c more than 7 has been associated with 3 times more increased risk of FTTB, while less than 7 is associated with a protective effect. So, my dear friends, any patients of tuberculosis must be examined for, must be investigated for random blood glucose, fasting blood glucose, or HbA1c. And any diabetic patients should be screened for patients for cough of any duration, not necessarily 14 days. Fever, unexplained weight loss, night sweats, hemoptysis, or X-ray should be done if there is any respiratory symptoms like cough, etc. And this should be confirmed by sputum microscopy. Gene expert, you know, the CBNet is available every district, everywhere now. And the liquid culture is, you know, the gold standard, should be done whenever it is possible. Lined probe is again, this very quick diagnosis can be done by this molecular assay. How do we manage this? Despite suggestions that diabetes may lead to more severe disease, death, and relapse, dosage regimen and duration of anti-tuberculosis drugs among these with or without TB are not required. National Tuberculosis Eradication Program does not say this 6 months treatment with the intensive phase of 2 HRZD for 2 months and HRE for 4 months continuation phase, and that is the recommendation. Diabetes often have complications like peripheral neuropathy that should be treated with pyridoxine. Here again there is a problem. Whenever there is treatment of diabetes and TB, there are drug-to-drug interactions. Rifampicin, which is key among the cocktail of anti-tuberculosis drugs, though through enzymatic induction, accelerates into hyperglycemia. It can increase the blood sugar level by antagonizing the action of sulfonylurea, but in some situations, isoniazid decreases the metabolism of oral anti-hypoglycemic drugs, increases the plasma level of such as the cytochrome P2C9 involved in metabolism of sulfonylurea. But it is thought that inducing effect of rifampicin far outweigh this inhibitory effect of isoniazid. This DPP4 inhibitor may cause immune paresis, and it has been shown that possibly it may worsen the outcome of TB management. The interaction with thiazolidinone, rosiglitazone is metabolized largely by CYP2A8, and rifampicin decreases the concentration of both rosiglitazone as well as pyrglitazone. There is also the suboptimal response of anti-tuberculosis drugs. In a cross-sectional study conducted in South India, significantly higher proportion of patients with DM demonstrated resistance to rifampicin. Similarly, it was also shown in other study that INH and PHA also has got lower serum level when treated with this diabetes mellitus. Therefore, routine monitoring of therapeutic drug response and fortification of TB regimen should be done. It means that use of higher doses of anti-tuberculosis drugs if needed, yes. And you can extend from the 6 months to 9 months treatment depending upon, I would say that this treatment, TDM is there, that there should be individualized treatment also if need be. Glycemic control, this is the very, very important step in the management of this. This accepted target for glucose control in diabetes is HbA1c less than 7, as recommended by ADA. Although the American College of Physicians recently recommended HbA1c level between 7 to 8. Next question is how optimal glycemic control can be achieved. We first address the choice. Choice is just three: biguanide, sulfonylurea derivatives, and insulin. Metformin is the first choice glucose lowering agents recommended in type 2 diabetes mellitus, and there is no reason why it should not be used in combination of TVDM, because we have got the extensive experience with this drug. Extremely low risk of hypoglycemia. Effectiveness is very good. Low cost, beneficial effect on the cardiovascular disease. This lack of clinically relevant interaction with rifampicin, and of course, potential benefit on TB itself. This is new information. This metformin as an adjunct therapy, the potentially new approach to TB therapy is to augment the protective host immune response. We report this anti-diabetic drug metformin controls the growth of the drug-resistant MTB strains, increases the production of mitochondrial reactive oxygen species, and facilitates some. So we can data case that the metformin is a promising candidate host adjunctive therapy for improving the effective treatment of TB. This management of this combination of TB-DM with insulin is the most preferred treatment in patients with severe TB because of anabolic actions, regulation of appetite, promotion of weight gain, low potential for drug interaction with anti-TB agents, and effective on producing general sense of well-being. Plus, that will reduce the pill burden, and so that will enhance the adherence to the TB regimen. And as recommended by RSSBI, insulin must be used in newly diagnosed DM patients with HbA1c more than 9, fasting blood sugar more than 250, ketone body, symptoms of hyperosmolarity states, and for those who are in catabolic state or lean-thin patients. In patients already on OAD, insulin may be added to ongoing therapy if the patient is poorly controlled and has got low BMI. Regular monitoring of glycemia is very, very important, and adoption of lifestyle intervention are advised. Appropriate dose adjustment for insulin are critical, as requirement may vary after attainment of glucose control. So as this MDR tuberculosis may be there, maybe more common in this, and delay in Mycobacterium TB clearance during treatment and treatment failure predispose patients with DM to an increased risk of primary MDR tuberculosis. Numerous studies have identified 2 to 9-fold increase in the risk of MDR among patients with DM. This CBNAT we have got, LPA we have got, liquid culture also we have. So it's mandatory, this all patients, sputum positive patients, they should be subjected to CBNAT. And that is, quickly we can diagnose the rifampicin resistance. So every case should be diagnosed so that we can rule out this MDR tuberculosis. Metformin again is a favorable pharmacological agent for MDR tuberculosis, along with the bedaquiline also. The metformin is known to restrict the intracellular replication of MDR strains. Of course, insulin will we have got H resistance, that is monopoly, and the first one shows that this 6 to 9 months to 1 year of regimen is there. We have got Bangladesh regimen whenever we have got resistant tuberculosis. Just recently on 24th of March, bedaquiline containing regimen, and that is roughly 11 months. We have started this regimen, bedaquiline regimen, just not this 24 months, but 11 months treatment, and that could be convenient now, reducing from 2 years to 11 months. So TB with HIV, you know that HIV is associated with diabetes. In a study in Tanzania and everywhere, glucose metabolism disorders have 6-fold more common among HIV infected individuals. Patients of aging, diabetes is more common. Growing number of people may have all these 3 diseases. And in such cases, again, drug-to-drug interaction of TB drugs and HIV drugs and this diabetes drugs, the interaction will be there. So clinician must be aware of this interaction. So recommendations of lifestyle should be tailored to the individual needs. Those patients who have got loss of weight, increased protein intakes should be there. Weight reduction will be considered in the obese patients. Different vitamins, especially the B6, B12, vitamin E should be added. Mild to moderate activity should be there. Alcohol, again, cessation of alcohol. No alcohol should be started. As Dr. D. Ram sir was asking about this, especially these patients. Permanent discontinuation of tobacco use and continue lifestyle and regular blood sugar monitoring. Again, is there this problem? Again, if the patient of TB-DM is associated with CKD, CKD is known to adversely impact the multiple immune functions, B cells, T cells, and substantially increases the risk of acute and chronic infections with TB, HIV, and hepatitis B. A study conducted in the tertiary hospital in North India, again, type 1 DM and high rates of positive Mycobacterium tuberculosis is there. Even in dialysis are there. But here there are certain drugs which the dose of this should be reduced. 50% dose reduction in ethambutol and TZD should be done. And insulin is the most preferred therapy whenever CKD is there with TB-DM. Similarly, the chronic liver disease, as with CKD, there are limited studies reporting the coexistence of TB-DM in patients with CLD. Treatment of TB in patients with CLD is challenging because due to the lower threshold of drug-induced toxicity, the first three line of drugs, INH, rifampicin, PZA, they are all have got the hepatotoxicity, and there will be problem in dealing with that. And there is recommendation is that there should be delay and deferred in TB treatment unless acute hepatitis are there. And again, similar to CKD, insulin is the preferred mode of treatment with TB-DM with CKD. There is a beautiful article in 2021, just in January, interaction of diabetes and tuberculosis translating research to policy and practice. And the recommendation and the key issue recommended by that TB control and associated with cardiovascular disease. In TB treatment, as TB is associated with worse TB outcome, TB treatment may have to be prolonged and intensified. But this National Tuberculosis Control Program again advised the 6 months only. TB is associated with drug resistance. The drug interactions are there, more side effects are there, more polypharmacy are there. These issues should be tackled. Among the glycemic control, it is difficult to achieve in the TB-DM, but metformin is the preferred oral drug, may improve TB outcome, and insulin is indicated for severe hyperglycemia. The DM is strongly associated with CVD. TB may further increase CVD. There are huge gaps in CVD management among people with DM and likely among people with TB-DM. Patients with combined TB-DM who have established CVD should receive antiplatelets, antihypertensive, lipid-lowering agents. Okay, sir. RSSDI has got clinical practice recommendation, and that must be reviewed or in consultation with the NTEP programs. And this public issue measure should be the improved coordination between government initiative, the NTEP and non-communicable disease committee, increasing awareness of DM and TB coexistence among patients and healthcare professionals should be there. Propagating importance of self-assessment of TB symptoms among patients with DM and implement the infection control measures and the DM treatment at TB centers to avoid contacts of sputum positive there. My dear friends, in nutshell, there is an unholy alliance between TB and diabetes. They both impact the presentation of each other. The TB patient should be screened for DM, and DM patient should also be screened for tuberculosis. And the treatment is challenging, but it should be tackled with metformin and insulin. And strategy will be that prevention of tuberculosis must continuously be emphasized. Even in India, although this TB preventive therapy in TB and latent tuberculosis should also be explored, although it is not just not given. Thank you very much.
So that was really an informative and useful talk covering all aspects related to tuberculosis and diabetes. So we can take up few queries, one or two questions.
It's a wonderful talk,
Dr.
Professor.
DP Singh. Yeah, Dr. DP Singh, one question from my side. A patient who is well controlled as far as glycemia is concerned, develops TB, he's on oral drugs, does he necessarily be shifted to insulin or he can continue with oral drugs?
If the patient is
Well controlled.
If it is well controlled, we shall continue with the oral drugs. Why I have told you that once the HbA1c is more than 9 or the recommendation is more than 10 or there are patient is not controlled, only then we shall add the insulin. Even in the mild diabetics, we should start with the diet, drugs and metformin. That's enough.
Dr. Deviram wanted to ask. Yes, please.
Yes, there was a traditional teaching that those who are diabetics should have a chest X-ray probably once or in 1 year or 2 years time. Would you agree to that, Professor DP Singh?
I have told you that all patients, I say that should be the rule. All patients of diabetes should be screened for tuberculosis. Should be screened for whenever they come for checkup. Should be. So 6 months to 1 year. I have even relaxed this cough duration. It is not 14 days. Even for few days of cough, we should screen for this. All tests should be done, not only for X-ray. But
I remember Professor S.N. Arya used to teach us same thing, that get a X-ray done in a year time. And the question raised by Dr. Birmani is also very important, because traditionally it used to be said that once a tuberculosis patient is found to be diabetic or vice versa, they should be started on insulin, which I personally never practiced in my practice. And as you said, if someone is controlled on one or the other drug, that's fine.
Yes, sir.
Sir, it is basically how you control it. If it is well controlled, as Dr. Virmani has said at the outset, then you need not change it. But it is only when the term uncontrolled comes, and that by the American Guideline Association, ADA Association, that if HbA1c is more than 9%, only then you think taking up the insulin, and that is a separate issue. The question what you raised, sir, that was the basic teaching in 70s, 60s and 70s, that annually they should be evaluated. Now the teaching is that any patient who is having cough of more than 2 weeks duration, you should evaluate with chest X-ray. And then you should rule it out. And particularly on all diabetics, it is mandatory.
Then even the cough duration may be reduced. Why do you say?
Don't wait
Yes.
for 1 year. Sir, wonderful talk, wonderful.
Even it is said that even patients who are non-symptomatic, some of the patients are found to be sputum positive by CBNAT. No cough, nothing, and still exactly the test was
nothing. A growing cachexia, you should just evaluate for tuberculosis. So the thing is that both in HIV as well as diabetes, everybody should be scanned for tuberculosis. That is mandatory.
Especially if
slightest suspicion of diabetic mellitus for tuberculosis is screened for it.
Especially, if a patient of uncontrolled blood sugar comes to you with history of loss in weight, I think X-ray is mandatory right from day one.
Yes.
Absolutely.
So I think we'll go to the next speaker. Thank you, sir. Can I have Dr. R.L. Agarwal, please?
Yes.
Chairperson.